Podcasting from eHealth New South Wales. This is Let's Talk eHealth.
Welcome to Let's Talk eHealth, where we showcase the projects and people of eHealth New South Wales. I'm Hannah Kunyapan and I work in the communications team at eHealth New South Wales. Today I'm joined by Simon Plummer, MedSync product owner at eHealth New South Wales, and Professor Naren Gunja, Chief Medical Information Officer at Western Sydney Local Health District. Welcome.
Thank you.
Thank you.
Now, in our last episode, we spoke about MedSync, focusing on upload and connect. Today, we're diving into role-based messaging. Now, in New South Wales hospitals, finding the right specialist quickly can be a challenge. So role-based messaging lets clinicians connect by role, hold video calls, and send secure messages in real time, essentially cutting out the guesswork of traditional paging. So, Simon, first to you, can you tell me a little bit about role-based messaging and how it came about?
Yeah, sure. So it came about as part of our business requirements when we were looking to build the mobile clinical communications platform and the tools. As you mentioned, MedSync Upload was our first feature, closely followed by the Connect feature. And then RBM is the latest addition to the MedSync suite of apps. RBM was piloted at Western Sydney LHD initially with only a handful of roles. But as I'm sure Naren will talk to, they now have many more roles in daily use across Western Sydney. The product was envisioned and developed closely with our Microsoft colleagues and the clinical groups, of which Naren was a big part. And Western Sydney LHD submitted requests to run a proof of concept, and it went from there, really.
What sets role-based messaging apart from the other communications tools that are currently in healthcare?
So currently there are no other platforms that allow you to send a chat message to a specific role rather than to individuals, which then saves time. Clinicians won't have to chase switchboards or check rosters or look up mobile phones, etc.
Now, we mentioned this on the MedSync podcast, but can you break down why role-based messaging was built into Microsoft Teams of all programs?
Yeah, sure. So leveraging our existing investments was extremely economical, as well as piggybacking onto the security systems in place to ensure that RBM exists in the most secure spaces possible. We then also have the ability to integrate into our other clinical systems and leverage the statewide infrastructure.
How has clinician feedback shaped the development of role-based messaging?
Close working relationships with Western Sydney LHD and Naren and his team, and our agile approach to enhancing adding features has been key, as well as surveying users for feedback and then using that data to continue to improve.
Now, Naren, over to you. You've been at Western Sydney Local Health District for 25 years. Can you tell me a bit about your role here? What do you do?
So I'm the Chief Medical Information Officer for Western Sydney. I've been here as a clinician, starting as an intern in the late 90s. And a medical student before that. So I'm an emergency physician at Westmead, also a clinical toxicologist in the inpatient space across the district as well. I started working in IT projects with the eMeds project was my first one. And then that led to the role of CMIO for the district.
All right, so you must have seen a lot of different programs over your time then at Western Sydney. What's your experience using role-based messaging?
So this was a really important part of my role. When I started, I vowed to get rid of faxing and paging. That was one of the things that I wanted to do as part of the CMIO role. Faxing is really all about e-referrals, but the paging part is essentially pages were implemented to be able to be carried and passed on from person to person as a shift roster continues. And if you think about how messaging to a person works, in order to be able to SMS someone, you need to know their mobile number. That was superseded by Microsoft Teams, which was a huge step forward for the state and for our district, because you no longer needed to know the mobile number of the person who you wanted to contact. You just needed to know their name. And Teams was a massive bonus, particularly during the pandemic when we were trying to increase our ability to contact people virtually. Then role-based message just takes that to the next level because you don't need to know the name of the person you're trying to contact. You just need to know their role. And that's where it replaces paging, because pages were all about contacting a role without knowing who was carrying that pager.
And how do you find you use it in a typical day? Do you have an example of when role-based messaging has supported specialist outreach?
So predominantly it is there to replace the pager for consults. That is the main use case. There are many other use cases, and we can talk about that. But mainly it is, for example, an ED doctor seeing a patient needs to consult a team. That could be the plastics team, the cardiology team, the respiratory team, my own team, the toxicology team. So instead of paging that team and waiting for them to ring back, paging is a one-way broadcast signal. You don't know whether the person received the page. You don't know if they're able to ring back at that time. When they ring back, you may not be there to receive the call. So there's so much closed loop communication that is not able to be done with paging. And that's what role-based messaging allows. That closed loop communication where you can send a message to a role, you know who is carrying that pager, that role in role-based messaging because they've checked into that role. And then you can see them acknowledge the message back, and you can have a conversation with that person, because RBM is not there to stop people talking to each other. It is there to facilitate that initial conversation. So you can just press the little telephone icon and ring that person back.
These are all really great benefits. What's your experience using it?
My experience is I've spent many years in the paging world. What RBM allows is people are now mobile. They don't want to be tethered to a telephone. So paging means you have to walk up to a landline telephone, page that person, and stand and wait there for that person to come through. The other thing that Simon also mentioned is you're constantly looking up rosters and ringing switchboard in order to find out who is supposed to be on for that team. You don't have to worry about all that with RBM. You don't have to look up rosters. You don't have to ring switchboard and wait to be put through. So all that waiting that you're doing by the phone is now gone. You can be walking around. You can be attending to other tasks or seeing other patients. You send that message out on your mobile phone. It's secure because it's happening on our Teams environment. And it can even be done on BYOD phones. It doesn't have to be a district issued phone. So all that waiting around a landline is now over. That's the biggest change. The other thing that RBM allows you to do is when you page someone, you can't send any details of the patient. RBM contextualizes that message. So the person receiving it knows what it is you're contacting them about. Pages are just random beeps where you just go, okay, someone is trying to contact me about something. You don't know who's trying to contact you. You don't know what they're trying to contact you about. So for the receiver, this is a huge benefit in that they are now able to see the details of the patient. They often look up the patient before they ring them back because they can see the results, they can see the scans, they can look up the history. And we have mobile EMR in Western Sydney, so the whole thing's mobile. You can be looking up the patient's case if you're on call, wherever you might be in after hours. You could be at home, you could be out as a on-call registrar.
Simon, tell me, how does role-based messaging integrate with other clinical systems clinicians use?
Yeah, so currently it's a messaging platform built inside Microsoft Teams environment for those closed loop chats that we've talked about. And because it leverages Teams, obviously you can start calls as Naren suggested and share screen and stuff like that. But you can also bring media, images and video into those RBM chats. And then from there, MedSync will allow you to upload that to the patient's record. In the future, we are actually looking to integrate the patient details card inside of RBM, as Naren was talking about there, to be able to actually search the EPR, which is the electronic patient record. So the clinicians won't need to manually type in details. They can just type in the patient's identifier and it'll populate that field for them.
And Naren, what's your advice to colleagues who say they might be too time poor to learn another platform such as role-based messaging?
It's very intuitive. It doesn't take a lot of time to learn. In fact, we've done almost no training whatsoever. We've just created a SharePoint site, some videos from eHealth, and we've just let people run with it. There's very little face-to-face or in the classroom, in fact, no in the classroom training whatsoever that we needed to do. It's extremely intuitive. People have just been clicking things and working out what they need to do. There are some FAQs that we put up for the common things that people encounter, and we've done an FAQ page for that. But training is very minimal. It's very intuitive.
And now looking ahead, first to you, Naren, how do you see role-based messaging evolving or playing a role in patient-centred care?
I think this is the way of the future. We're not going to be going back to pagers. We've now even got non-clinical task management happening in role-based messaging now. Our orderlies now use RBM to get tasks to go pick up blood products, as an example.
Simon, your thoughts?
So on the success of what we've seen in Western Sydney, we've actually had requests from other OHDs where clinicians have gone, especially JMOs, have gone on rotation to other OHDs and hospitals and have sort of said, why aren't you using RBM? And so then they've sparked questions. It's come through back to us, how do we get RBM? And so we're kind of in that sort of discovery process at the moment where we're going to leverage the success we've had in Western Sydney, speak to the other OHDs, show them how it's working, and hopefully they'll be interested and we can start rolling out there too.
It's been a pleasure having Simon and Naren on the podcast today to walk us through role-based messaging. Definitely an exciting feature for healthcare teams looking to stay connected. For the listeners, thanks for tuning in. For more on role-based messaging and MedSync, head over to our website or listen to our other podcast episode.
Thanks for having us.
Yeah, appreciate it. Thank you.
Thanks for listening to Let's Talk eHealth New South Wales. If you enjoyed the show and want to learn more, visit www.ehealth.nsw.gov.au.